Endophthalmitis is one of the true sight-threatening emergencies in ophthalmology because once infection and inflammation spread inside the eye, the damage can escalate very quickly and the final visual outcome may depend on how fast the condition is recognized and treated. This is not just a red painful eye after a routine procedure. It is a deep intraocular inflammatory process that often means microorganisms have entered a closed and delicate space where even a relatively small infectious burden can trigger major structural damage. This video is going to cover endophthalmitis, which refers to severe inflammation inside the eye, usually involving the aqueous and the vitreous, with the vitreous being the gel that fills the back of the eye. In most important clinical cases, the process is infectious, although some sterile inflammatory reactions can mimic it and make early assessment more challenging. The disease is broadly divided into exogenous and endogenous forms. Exogenous endophthalmitis means the causative organism entered the eye directly from outside, which is why it is classically associated with cataract surgery, intravitreal injections, open globe trauma, filtering procedures, or extension from a severe corneal infection. Endogenous endophthalmitis is different because the organism reaches the eye through the bloodstream from an infection somewhere else in the body. That distinction is important because it changes the likely source, the likely organism, the workup, and the overall strategy. In a practical sense, endophthalmitis matters so much because the retina, vitreous, and other internal ocular tissues are highly specialized and they do not tolerate uncontrolled infection or intense inflammation very well. The classic presentation includes reduced vision, ocular pain, redness, and photophobia, meaning light sensitivity. Many patients will also describe floaters, blurred or smoky vision, tearing, eyelid swelling, or a heavy aching sensation in the affected eye. In postoperative cases, one of the most important historical clues is when the patient says the eye seemed to be recovering normally and then suddenly worsened, especially over hours to a few days. On examination, you may see conjunctival injection, corneal edema, anterior chamber cells and flare, fibrin, and hypopyon, which is a visible layering of inflammatory material or pus in the front chamber of the eye. Vitritis is another hallmark feature and simply means inflammatory debris suspended in the vitreous gel. Once vitritis becomes dense, the red reflex may be reduced and the fundus view may become hazy or completely obscured. Not every case looks explosive at the beginning, however. Delayed onset postoperative infection can present more quietly with recurrent inflammation, persistent mild pain, or gradual decline in vision that never fully normalizes after surgery. In endogenous disease, the patient may also have fever, malaise, sepsis, endocarditis, diabetes, immunosuppression, intravenous drug use, or recent hospitalization, so the eye findings may be only one part of a bigger systemic picture. The causes depend heavily on the clinical setting. In exogenous endophthalmitis, organisms are introduced directly into the eye during surgery, injection, trauma, or by inward spread from severe infection on the ocular surface. Post-cataract surgery and post-intravitreal injection cases are often bacterial, and although these complications are relatively uncommon, they are among the most feared because these procedures are performed so frequently in modern ophthalmic practice. Trauma-related endophthalmitis is particularly dangerous because contaminated materials such as soil, plant matter, or metal fragments may be forced into the eye, increasing the chance of a highly virulent infection. Delayed postoperative cases may involve less aggressive but more indolent organisms, which can produce chronic or recurrent intraocular inflammation rather than an immediately dramatic presentation. Endogenous endophthalmitis, on the other hand, occurs when organisms see the eye hematogenously, meaning through the bloodstream, so the clinician must think beyond the eye and search for a source elsewhere in the body. Risk factors in endogenous disease include bacteremia, fungemia, endocarditis, indwelling catheters, diabetes, malignancy, immunosuppressive states, recent invasive procedures, and intravenous drug use. From a pathophysiology standpoint, once organisms enter the eye, they can replicate inside the vitreous cavity and trigger an intense inflammatory response. And that combination of microbial burden plus host inflammation is what causes such rapid tissue destruction. Diagnosis is primarily clinical and should be approached as an ophthalmic emergency requiring urgent specialist involvement. The history often points strongly in the right direction, especially if there was recent intraocular surgery, intravitreal injection, trauma, or a systemic infectious risk factor. Visual acuity is essential because the presenting level of vision helps assess severity and also has prognostic relevance. Slit lamp examination may reveal corneal edema, anterior chamber reaction, fibrin, and hypopyon, while posterior segment examination may show vitreous haze, retinal involvement, or an absent clear view to the fundus. If the posterior segment cannot be visualized because media opacity is too dense, B-scan ultrasonography is especially useful because it can reveal vitreous opacities, membranes, retinal detachment, choroidal thickening, or retained intraocular foreign body in trauma cases. Microbiologic confirmation is usually pursued with vitreous or aqueous sampling for smear and culture, and some centers also use molecular methods such as polymerase chain reaction to improve organism detection. The key practical message is that you should not wait for culture results before initiating treatment when the clinical picture is convincing, because this is a treat first and confirm as you go condition. In endogenous cases, diagnosis also means looking for the hidden source, which may involve blood cultures and a broader medical workup, because identifying the systemic origin can be just as important as treating the eye itself. Treatment is urgent and usually begins with intravitreal antimicrobial therapy because direct injection into the eye achieves concentrations that topical therapy alone cannot reliably reach in the vitreous cavity. In acute bacterial cases, empiric therapy commonly includes intravitreal vancomycin plus ceftazidime in order to cover a wide range of gram-positive and gram-negative organisms while culture data are pending. In many settings, clinicians first obtain a vitreous or aqueous specimen and then immediately proceed with antibiotic injection, an approach often described as tap and inject. Pars plana vitrectomy is considered in more severe cases, especially when presenting vision is very poor, when the vitreous is densely involved, when the diagnosis is uncertain, or when there is inadequate response to initial therapy. In simple terms, vitrectomy means surgically removing infected vitreous gel to reduce the microbial load, clear inflammatory debris, and improve drug distribution and visualization within the eye. Adjunctive measures can include topical steroids, cycloplegics, and pressure-lowering therapy where appropriate, but these are supportive rather than definitive treatments. Endogenous cases often require systemic antibiotics or antifungals as well, because the eye infection may be only one manifestation of an active infection elsewhere in the body. Prevention is also a major part of the story, particularly for injection-related and postoperative cases. And core preventive measures include povidone iodine antisepsis, attention to lid and lash contamination, and avoiding procedures when there is active external infection. So the high-yield principle is simple. Suspect early, sample quickly, inject quickly, and escalate quickly. So, the major takeaway is that endophthalmitis is a vision-threatening intraocular emergency that most often enters the differential after cataract surgery, intravitreal injection, trauma, or bloodstream spread from a distant infection. The warning signs are worsening vision, pain, redness, hypopyon, and vitritis, especially when the timing fits a recent invasive eye procedure. Diagnosis is mainly clinical. Ultrasound helps when the view to the back of the eye is poor, and cultures support the diagnosis, but should not delay treatment. Management usually centers on urgent intravitreal antibiotics, with vitrectomy in selected or severe cases, and systemic treatment when endogenous infection is suspected. The safest mindset is to treat endophthalmitis as a race against time, because rapid recognition and decisive early management are among the few factors that can still meaningfully improve the visual outcome. To learn more about the diagnosis and management of endophthalmitis, be sure to check the link in the description below.